Department of Geriatric Medicine Grand Rounds. This CME activity is sponsored by the Hawaii Consortium for CME, a joint venture between the Hawaii Medical Association and the John A. Burns School of Medicine, Hawaii. Before I introduce our speaker, I have a few housekeeping comments. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. As a reminder, evaluations are required for CME. You can find evaluations by following the link in the chat or at any time on our website and email advertisement. Your comments are very important to our planning committee for future programs. As you know, all sponsors of CME are required to execute a conflict of interest policy. Dr. Nakagawa has disclosed that he has no relationships with commercial supporters that could be perceived as a conflict of interest. So now it's my great pleasure to welcome our speaker for today, Dr. Shunichi Nakagawa. He is an assistant professor of medicine and director of the inpatient palliative care services at Columbia University Medical Center. He graduated from Hokkaido University in Japan, completed a residency in general surgery in Japan, a residency in internal medicine at Cleveland Clinic, Ohio, and then fellowship training in geriatrics and hospice palliative medicine at Mount Sinai in New York. He joined Columbia University Medical Center as faculty in 2013. He specializes in symptom management and goals of care in seriously ill patients, and also teaches palliative medicine and medical communication to a variety of learners at different levels. His research interests include palliative care in heart failure patients who are on mechanical circulatory support and communications about treatment preferences before high-risk surgery. Please join me in welcoming Dr. Nakagawa. He will be talking about giving bad news.
Thank you, Dr. Masaki, and also Dr. Uemura for inviting me for this talk. So today I'd like to talk about the communication, especially about giving bad news. So there's no disclosure. Over the next 45 minutes, what I'd like to do is I'd like to talk about the definition of bad news. And then I want to talk about the 6-step spikes protocol. And after that, I want to show you a couple of videos about communication. And then I would like to discuss how it is going. Okay. So let's start about the definition. What is bad news? What do you think about it? Usually I get a response from the audience, but because this is Zoom, it's very difficult. So first definition is bad news is any news that seriously and adversely changes a patient's view of his or her future. This is a broad definition. Sounds reasonable. But I think what is most important is gap. Bad news is the gap between the patient's expectations and the reality of the patient's medical condition. So, for example, like we diagnosed you with cancer, chemotherapy is not working, your time is getting short. So these are obvious bad news, but not only that. For example, patient is expecting to go home like tomorrow, but for whatever reason, it was postponed to the next week. This is also the bad news. Because there's a discrepancy, there's a gap between the patient's expectation and reality. So what this means is I think as long as you are communicating, you are talking with patients and family, it's impossible. It's impossible for you to avoid giving bad news because any news could become a bad news. So question for consideration. What is difficult about communicating bad news and where do you get stuck? Is it difficult? It may not be a big deal, but it is difficult. The very common response I hear from the audience is that you might feel guilty if something is not going well, and you have to tell that to the patient or family. You feel bad because you feel that you did something wrong. I would say you should not feel guilty because you are a medical professional and you are doing everything you can to make the things better. I think to be blamed is cancer or heart failure or dementia, not the patient, not you. So you don't have to feel guilty, but it is difficult. The other reason I hear is when we give the bad news, patient becomes emotional, and then we don't know how to deal with that, and that makes it difficult. So I'm going to touch upon how to address emotions in the later. And the next question is, why do you have to know how to break bad news? Does it matter? You know, we are medical professional. We are going to make a right diagnosis. We are going to give the best treatment available. So to give out bad news in a good way or bad way, does it matter? Who cares? Actually, it does matter. It does matter a lot. You know, the many studies have shown that if we give the bad news in a good way, that has a lot of impact on the decision making of the patient and family, especially at the end of life. So it does matter. It's really important. So here I want to share the basic skills to break bad news. This course we call spikes. And actually, this spikes protocol is not only when I give bad news, but also I use this every single encounter, every day with my patients or family. So I'd like to share this with you today. So this is a mnemonic. So S means setting, P means perception, I means invitation, K means knowledge, and E means emotions, and S means summarize and strategize. So let's go one by one. So what setting means? This setting is the most important when we give bad news. I'm a palliative care consultant, and when I get a consultation for goals of care, and then I expect a family meeting, probably I spend more than 50% of my time and energy for the setting. The better job you do here, the easier the actual conversation goes. So you need to be aware of that. So what does this mean? First, you have to prepare yourself. You have to know the medical facts. So what is the diagnosis of the patient, and what is the treatment he has been going through so far? What is the available treatment options? What is the prognosis? So you need to know the medical facts as much as possible. Having said that, it's also difficult to know everything. I'm just palliative care consultant, so I don't know the latest, most sophisticated way of treating the pancreas cancer. I don't know. I don't know what is the most state-of-the-art way of treating heart failure. I don't know. But I think the important thing is you have to know what you don't know. And you have to, if I don't know the details of chemotherapy, I can bring the oncologist to the table. And if I don't know the indication of dialysis, I can bring the nephrologist to the table. You know, nephrologist or oncologist might be busy. So in that case, you have to expect what is the question they are going to ask you. And then you have to ask that question to that specialist. So if they are going to ask me about, the chemotherapy, and I don't know about it, I'm going to ask oncologist, Dr. Smith. They are going to ask about why they cannot get chemo. So what should I say? So you try to prepare yourself as much as you can. This is where you have to use your medical expertise. And also you have to think about who are going to join that meeting. Who will join from the family? if you are going to talk about, only, potassium is like 5.6, then you don't have to bring the family. But if you are going to tell them about the CAT scan result, the cancer is progressing, and we have to talk about the next chemotherapy, maybe we should bring the next of kin. So in this patient, who should be there? Is that the wife? Is that the parents? Is that the children? Is that the siblings? So you have to think about who is the key person in the family. How many of them do they want to come? So you have to think about those things and then prepare. Also, you have to think who should join from the medical side. I talked about a specialist like oncologist or cardiologist, but not only that, maybe you should bring the nurse. Maybe if we are going to talk about the discharge options, maybe social worker should be there. So who should join the meeting? That you have to prepare. That is a part of the setting. And you need to have a pre-meeting among the medical team. This is the most important. The bottom line is when you break bad news, the medical side have to be on the same page. Sometimes I come to the ICU and then I see the patient, and the patient looks dying in front of me. But even if I feel that way, if the other primary team, like oncologist or ICU team or the other people, if other providers don't feel that way, I cannot share what I feel, because that's only confuse the patient and family. So depending on the content of the news you are going to break, you have to get in touch with the other providers. Most of the time, you should identify the primary stakeholder. That means the physician who has the longest relationship with that patient. Could be primary oncologist, could be primary cardiologist, and then identify that physician, and then you need to get in touch with that physician. And you have to check the environment. You need to pay attention to the privacy, and you should bring the chair to sit down to make the eye level even, and you should bring the box of tissue. We are not going to talk about our vacation. We are not going to talk about yesterday's movie. We are going to talk about life and death, and very, very serious thing about this patient. So you need to make enough effort to secure the best setting. Sometimes it's difficult because sometimes you have to do in the emergency room. Sometimes you have to do in the shared room, so you don't have enough space. But still, even if you do the shared room, and then the 3 family members are there, and the 5 providers are there. So there's no space for everybody to sit down, but at least you can bring one chair at the bedside, and somebody who is going to lead the conversation should sit down at the bedside. So this is really important. And make sure all the relevant or request parties are present, and you turn off your beep or phone. And also, you should bring the professional translator. Then don't let the family translate. If all the patient and family cannot speak English, that's easy. You have to use a translator, the Spanish translator. But a very common pitfall is that the patient cannot speak English, but the daughter can. And the daughter kind of volunteers, oh, I can translate. And then because you are so busy, you are so tempted to take that offer, not good idea. Because 2 reasons. One is, in this kind of sensitive conversation, I need the patient to hear what I say word by word, but the family translator cannot do that. Also, family translator is going to insert their interpretation to my statement. So because of 2 reasons, we should avoid the family translator. Okay, so all of these are setting. P is a perception. Before we start tell what we know, we have to gauge how much, what does the patient knows already. We call this ask, tell, ask. we doctors are very smart. We know a lot of things. So we tend to start by saying what we know. Not a good idea. First, you have to gauge how much they know. So how can we ask a question? How should you ask? You can ask like this. What do you understand about your condition? This is okay, but this could backfire. I have a bad experience that when I asked this way, the family kind of snapped at me. I understand a lot of things. I'm not stupid. So, this could sound offending. So the better way of asking is what have doctors explained to you so far? How have you been told? We know doctors are bad in communication, so blame other doctors, but not the patient and family. And while you are listening, you pay attention to the two things. One is their level of comprehension, their health literacy. They might be well educated and their comprehension is very good, or their health literacy might not be so good. Also, how much they know. They might have known a lot of things already based on the conversation yesterday, or they might have no idea. So you gauge these two things while you are listening. And also, I try to catch the vocabulary that they are using. For example, if they say that I was told that I have some spot in my lung, then I catch that. And then when I explain, you said that you had a spot in your lung. Actually, that spot is a cancer, and that is getting bigger. This way, you can make your explanation less difficult. So this is perception. I means invitation. What does this mean? Before you talk, you have to know, how much the patient wants to know, because you cannot force the information to somebody who does not want to hear that information. Patient has a right to know. Patient also has a right not to know. So this depends on the personality or characteristic or preference. Could be cultural variation. They might want to designate someone to communicate on his or her behalf. So how can we ask? We have to gauge this. So when I expect a very serious family meeting, like tomorrow, I go check the patient like the day before or in the morning. Let's say with family meeting is scheduled at 2 p.m. I ask the patient, Mr. Smith, let me ask you a question which I ask to all of my patients, just to normalize. And some patients, people have different opinions. People look at the thing different way. Some patients wants to know everything about his or her disease, even if those are not good news. And some patients don't want to hear the detail. And then some people want doctors to talk to their loved ones. In your case, I think your wife or your son. So what kind of person are you? If they say, of course, I want to know everything, then we have to go to the patient room at 2 p.m. But if patient says, no, I don't want that. I mean, you please just talk to my wife. Then you don't have to go to the patient room at 2 p.m. You can just go to the different room with the family at 2 p.m. So this could be the part of the setting, but you need to make sure the patient is ready or is willing to be involved in the conversation. And every time you change the subject during the conversation, you get a permission. Is it okay if we talk about how your medical condition is? Is it okay if we talk about the next step? Is it okay if I share how much time you have left? So every time you change the subject, you ask a permission. Also, this is the timing for you to give a warning shot. You don't start flat out saying you have a cancer, you are dying. You don't do that. You give a warning shot. You can say something like, I'm afraid I have some bad news. Or the very common phrase I use is, we are very concerned about you. We did a CAT scan yesterday, and we are very concerned about the result. Is that okay to talk about it? So by giving this warning shot, you can prepare them that something bad is coming. And also you can make sure that information you are going to give is very bad. So you can make sure they understand the gravity of the situation. So this warning shot is very important. So only after you did a good job in setting, only after you did a good job in perception, only after you did a good job in invitation, then for the first time, you can tell what you know. This is the knowledge. And here, you have to speak slowly and clearly and simply. Here, I have two rules. One is a 50% rule, one is a 2-minute rule. 2-minute rule. Regardless of how complicated the situation is, you need to be able to summarize that within 2 minutes. Okay? Regardless of how complicated the situation is, you need to be able to summarize that within 2 minutes. Sometimes I hear the resident keeps talking on and on and on, like 5, 10, 15 minutes. You know, they don't understand it. Even I don't understand what they're talking about. Okay? And if you cannot do that, if you cannot summarize within 2 minutes, I think your preparation is not good enough. This is what you can prepare. This is what you can practice even before starting the family meeting. So, you know, don't talk more than 2 minutes. The 50% rule is if you are talking more than 50% of the entire conversation, I think you're talking too much. You don't have to, and you shouldn't. You know, when I talked about the perception, we have to listen to what patient says. So you don't have to spend more. You don't have to keep talking more than 50% of the time. And here, you already know how educated they are, how much they know. So you have to make adjustment inside you, and then you deliver the news. You do not use medical jargon, utilize their language, and consider their health literacy. Okay, and allow silence. We are so uncomfortable when nobody is saying anything. It's okay to be silent. If you don't know what to say, don't say anything. Sometimes people becomes, doctors become so uncomfortable, and then nobody is saying anything. You started to say about white count, creatinine, chest X-ray, doesn't help, okay? If you don't know what to say, don't say anything. It's okay to be silent. Sometimes I remain silent because I don't know what to say for 5 seconds, 20 seconds, sometimes even 1 minute. I don't know what to say. It's okay to be silent. And do not rush into the further discussion. So here, you deliver the news. You basically dropped a bomb. Cancer is progressed. Chemo is not working. Your time is getting shorter. What happens? They become emotional. They started to cry. They become upset. They might be yelling at you, and you start to get nervous because you don't know what to do. This is the most difficult part of giving bad news. And during the conversation, during the communication, we have two kinds of data. One is the cognition, one is the emotion. Cognition is something that we are very good at. This is about thinking, reasoning, and judging. This is what we can control. This tells us what patients understand rationally. We talk about it. Emotion is something we are not good at. And this is, we cannot control it. It's involuntary. And we don't talk about it. You have to catch the emotional cue by looking at their flash of worry, their expression, their body language. So you have to catch the emotional cue. And is it important to address emotions? Is it important? Does it matter? Who cares? I mean, again, we are making a right decision. We are giving the best treatment. So why do we have to care about the emotion? I think the very good reason is we have to be humane. Before being a physician, we have to be humane, and so we are talking to the human being, and then human beings are emotional, so we have to address emotion. That's a very good, nice sounding reason. I do have a more selfish reason, which I want to share. You know, at the end of the day, we are medical professional, so we need to talk about the next step, what treatment options, or how to take care of this patient. And patient and family also have to talk about it. But as long as people's brain is overwhelmed with emotions, brain is not able to absorb the cognitive information. So that's the reason why we have to address emotion first. We have to talk with cognition, but if the patient is overwhelmed with emotions, cognition doesn't work. So that's why we have to address emotion. How do we do that? Silence, if you look at textbook, it says so, the silence, active listening, we talked about it. And you have to show empathy, and you have to validate their feeling. These things will help with, most emotional reactions. This is what I said, when one is emotional, cognition doesn't work. This sounds good, but the question is how? How do we do that? How do we show empathy? How do we validate the feeling? So I want to share the two basic skill toolkit to address emotions. We call this nurse statement, and we call this wish statement. First is a nurse statement. This is another mnemonic to address emotions. N means name the emotion. Whatever it is, you just name it and say it out loud. This is very powerful. I use this all the time. You can say like, it sounds like this has been frustrating. You look surprised. You look shocked. Whatever it is, you just name it and say it out loud. It's very powerful. The key is you can be wrong. If you are wrong, they're gonna correct you. You look upset. I'm not upset. I'm shocked. Oh yeah, I hear you. It is shocking. Okay, so it's okay to be wrong, but to name the emotion out loud is very powerful. You either understand the emotion. Okay, never say, I know how difficult this is for you, or I understand how bad this is for you. Never say that, because you never understand how difficult this is for them. You never understand how bad this is for them. Instead, what you should say is, it must be so hard to be in the pain like this. Or the phrase I use is, I can only imagine how difficult this is for you. This is true, I can only imagine. R is the respect. I'm so impressed that you've been able to keep up with your treatment. And I'm so impressed, you have been here every day, 1 hour each way at the bedside. So I'm so impressed at how much support and the love you have been providing to a loved one. I'm so impressed. S is the support. Whatever decision you make, my team will be here to help you and your family, regardless of your decision. Sometimes I get blank. I don't know what to say. So in that case, we explore. The very useful phrase is tell me more. Tell me more what's in your mind right now. Tell me what do you mean by that. Tell me more. And let them talk. And while I'm listening, I try to go back to naming or understand or respect or support. So this is the basic skills to address emotion. Nurse, nurse, nurse. We keep nursing to address emotion. The other skill is a wish statement. Very common scenario is you just explained, the patient, we cannot give the chemotherapy anymore. And right after that, patient asks you, doctor, is there any other treatment? You're like, oh gosh, I just explained to you. This happens all the time. Why do they keep asking the same question? Is that because of your explanation? No, I think your explanation is very, very good, beautiful. Is that because of the health literacy? No, they are very educated. They are very smart. They keep asking the same question because they are still emotionally overwhelmed. If they are crying, if they look upset, it's relatively easy for us to catch the emotional cue because it's there, it's obvious. But sometimes they look totally okay, but they keep asking the same question. This is another emotional cue because this is a sign that the brain is not absorbing your beautiful explanation. So very common pitfall is you counter like this. I'm sorry, but I cannot offer chemotherapy anymore because your cancer has so progressed, because your kidney function is not good, because the white count is elevated, because your functional status is poor, blah, 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 blah. And they keep asking the same question. Instead, what you can say is, I wish I could offer chemotherapy and silence. Don't say anything else. This I'm sorry and I wish, these two things are saying the same thing, but I'm sorry sounds apologetic. You don't have to be apologetic. Again, you are professional and you are giving the best treatment possible. To be blamed with the cancer or heart failure or dementia. So you should not sound apologetic. And when you say, I'm sorry, you are standing afar from the patient and you are feeling sorry for them. Instead, when you say, I wish, you put your position more towards the patient and family side, and you can imply that you cannot give chemotherapy. Also, you have to be careful when you say but. When I was a fellow and I was in this training for communication, I was specifically told, try not to use but as much as you can, because when no matter how beautiful statement you make, as soon as you say but, that effect is gone. And then whatever you say after but is going to be emphasized. Sometimes, I use that effect intentionally. For example, how does it sound to you? Like, your time is getting shorter, but we'll make sure you're as comfortable as possible. Okay, this is statement A. Statement B is we'll make sure you're as comfortable as possible, but your time is getting shorter. Okay, how does it sound to you? I'm saying the two exact same thing, but just changing the order of saying, order of the statement, but it sounds totally different. So I think you should pay attention to these small things. And when I said this in the past, one medical student raised their hand and asked me, Dr. Nakagawa, sounds like that you are just manipulating your language. And my response was, that's exactly true. We are medical professional and we know how important this communication is. And we know how sensitive we have to be. So that's why we pay attention to the no statement, we statement. That's why we pay attention to the order of statement before and after but. So if you define that as manipulating language, that's exactly what we need to do. So, if they keep asking the same question, maybe first couple of times I might think that my explanation was not clear enough. So I answer like, I try to explain a couple of different ways. But if they keep asking the same question, I think that this is the emotional cue. So I say like, I wish things are different. If the patient asks me, doctor, can I make it to the Thanksgiving? Can I make it to Christmas? I say, I wish you could. That's it. Don't say anything else. And so, potential pitfalls is you try to answer emotion with facts and moving on to strategy too quickly. And when I think that I did a decent job addressing emotion, and now I want to talk about the next step, what do I need to do? Yes, I need to make an invitation. I've given you a lot of information. Do you think it will be okay if we start talking about the next step? If the answer is anything other than yes, then you have to stick to the emotions. You have to address emotions. Sometimes you have to stop the conversation and then you have to follow up the following day. If they are so emotionally overwhelmed, no matter what you say, they are not going to absorb the information. So it's okay to stop the conversation. And summarize and strategize is at the end of the conversation, you have to gauge how much they understand it. So how do you ask? I mean, again, you can ask, so did you understand what we talked about? Again, this could backfire. The better way of asking is, so we talked a lot. So how will you explain all of this to your family? Sometimes I ask this question to gauge the understanding. And make a follow-up plan. The closing statement I usually use is, we talked a lot. Let's stop the conversation here. I think you need some time to digest what I told you, and then you need the time to discuss things among yourselves. Maybe we can follow up the conversation like tomorrow or like after the weekend. So this is my generic closing statement. The pitfalls of thinking about S only from your perspective. You want to talk about the discharge planning, you want to talk about the code status, but don't bring your own agenda. So I cover the spikes and the nurse and the we statement. Okay. And energy words. Do you want us to do everything? Please don't say this. Who say no to this? We'll do everything anyway. There is nothing more we can do. This is, I think this is a very stupid statement. There are still lots of things we can do. If you add, there's nothing more we can do to treat cancer, that might be true. But don't stop there. Withdrawal care, and this is also very common. This is one of the pet peeves. Care always continues. I think the right way of saying is a withdrawal of the life-sustaining treatment, withdrawal of the life support. I also don't write the doctor saying, it's your decision. It sounds to me that we are not responsible, you are responsible. I think rather than that, the better way of saying is, based on what we discussed, this is what I recommend. This is what I think physicians should say, in my opinion. So now you learned about the nurse statement and wish statement, and the spikes. So I'll show you a couple of videos. So what I want you to do is you pay attention to the skills being used and the skills not being used. Okay, so let's start.
You have cancer. Ms. Berry, you have advanced metastatic ovarian cancer.
Go on.
You are Professor, Ms. Berry.
Like yourself, Dr. Klekian.
Yes. Now then, you present with a growth that unfortunately went undetected in stages 1, 2, and 3. Now it is an insidious adenocarcinoma.
Insidious.
Insidious means undetectable at an early stage.
Insidious means treacherous.
Shall I continue?
Oh, by all means.
Good. In invasive epithelial carcinoma, the most effective treatment modality is a chemotherapeutic agent. We are developing an experimental combination of drugs designed for primary site ovarian with a target specificity of stage 3 and beyond administration. Am I going too fast?
No.
You will be hospitalized as an inpatient for treatment each cycle. After the initial 8 cycles, you will have another battery of tests. The antineoplastic will inevitably affect some healthy cells, including those lining the gastrointestinal tract from the lips to the anus and the hair follicles. We will, of course, be relying on your resolve to withstand some of the more pernicious side effects. Ms. Berry,
Oh, I beg your pardon.
Do you have any questions so far?
Please go on.
Perhaps some of these terms are new.
No. You're being very thorough.
I make a point of it, and I always emphasize it with my students.
Oh, so do I. Thoroughness, I always tell my students, but they are constitutionally averse to painstaking work.
Yours too.
Oh, it's work.
Okay, so for the sake of the time, I usually ask the audience that what do you think about this conversation? Do you think that this conversation is good or not so good? And I want to see the response, but for the sake of time, probably most of you feel this is not good. So why is that? Or did he do well? Let me tell you, for the sake of time, I'm sorry, we have only 10 minutes more. So the, in terms of skill, what is the setting? I think it was very private. And then he was standing initially, but he sat down. So he did a good job in setting. He kept checking about the invitation. Am I going too fast? So he kept checking. Also, and then, so he did a lot of things in a good way, but still we don't feel this communication is not good. Why is that? I think the, I think the biggest reason is he's not addressing the emotion at all. When this video started with you have a cancer, how did she look? She looked shocked. So you could have said some naming statement. You look shocked, you look surprised, or understand statement, it must be so difficult for you. Or you could have said, I wish I had better news. Okay, this situation is terrible. This patient was diagnosed with aggressive cancer. She has to go through the aggressive chemotherapy. We cannot change those facts, but just by inserting the simple nurse statement addressing emotions, I think you could make the quality of this conversation much, much better. Okay, that's the point of this video. Next.
Well, folks, every few days I have to tell a man or a woman something I don't want to. I've been practicing medicine for 29 years and I still don't know how to do it well.
Why don't you just say it flat out?
All right? You have a cancer. Advanced.
Okay, how do you feel? I really want to see, how you feel. When I show this video, I think more people think this communication is not good, or many people feel uncomfortable. So what went well? What did he do well? I think he did a beautiful warning shot. I think 95% of this video clip was a warning shot. He was saying that, I don't know, I have been doing many years, but I don't know what to say. This is a very, very good warning shot. So why do you feel uncomfortable? Probably because this patient expression right here, I mean, he looks sad. I personally think that this conversation is pretty good. I assume this is the kind of a rural area, and this patient has a long, like years of relationship with this patient. And the doctors gave a lot of beautiful warning shot. And then the patient requested the doctor and then just say it flat out, simple. And then the doctor just followed that instruction. So I think this is a sort of very beautiful way of giving bad news. You might feel uncomfortable because this expression, because the patient becomes emotional. But you know, we cannot change the fact that this patient has a cancer, and then we have to deliver the news in a way, the best way possible. And sometimes I hear the doctors feel uncomfortable, and then doctors weaken the statement in order to make the patient, you know, less unhappy. I think that's wrong. You know, we have to give the news in a simple way, as simple as possible. You know, we know how to address emotions, but we don't have to soften the statement, in my opinion. Okay. Next.
What do you think the chances are of a guy like you and a girl like me ending up together?
Well, Lloyd, that's difficult to say, and we really don't.
Hit me with it. Just give it to me straight. I came a long way just to see you married. Just least you can do is level with me. What are my chances?
Not good.
You mean not good like 1 out of 100?
I'd say more like 1 out of 1,000,000.
So you're telling me there's a chance? Yeah!
Okay. So the point of this clip is, you know, she gave a lot of warning shot. And, you know, initially, in the beginning, I told you that bad news is a gap between the reality and expectation. So, you know, 1 out of 1,000,000 was not bad news for this guy. So you have to know the patient expectation. That is the point of this video. Okay, so I'm going to skip this next 2 slides. So this is a piece I wrote. You know, I used to be a surgeon, and then I did a surgical training, and as a palliative care fellow, I did a communication training. And I think that the process is the same. This is what I wrote. You know, difficult communication is really a procedure, and learning its skills is surprisingly similar to learning surgical skills. What I mean by that is, you know, when I used to be a surgical resident, and I expect the like cholecystectomy tomorrow, I started the preparation the night before. I look at the textbook and I did the image training. You know, I'm going to put the incision here, this big, and then I cut this artery, that artery, and then I'm going to remove the gallbladder. And then I do the image training as much as I can, and then I jumped onto the procedure. Sometimes I did well, sometimes I didn't do well. Sometimes, you know, the senior resident took over my case. After that, I had to reflect. So what went wrong? Why my senior took over the case? Maybe I tried to cut the wrong artery. Maybe that I went to the different direction. And then you have to, I wrote it down, and I utilize that for the next procedure. You know, communication is the same. Before the meeting, you have to prepare yourself. So how do you make the your 2-minute summary? How do you summarize? And if they ask this question, how do I answer? How should I phrase it? So you have to try to prepare yourself as much as you can, and you jump onto the conversation. Sometimes you do well, sometimes you don't do well. And then after that, you have to reflect. You know, that my answer to that question was not clear enough. That's why patient looked confused, or patient became so upset, maybe because the way I phrased that was not good. So I tell you that no matter how many years or how many cases or how many conversations you go through, if you don't go through this mental preparation procedure review, you are not going to get better. I can tell you that. Only practice makes perfect. So the conclusion is, giving bad news is a core skill, and following spikes will help ensure you have a plan when giving bad news. And it should be uncomfortable to play bad news, regardless of how experienced you are. I have been doing every day for like years, 7 years. And no matter how experienced I am, I feel uncomfortable. When I say that cancer gets worse or you are dying, I feel uncomfortable. So I think it's okay to be uncomfortable, or I think we should feel uncomfortable when we give bad news. So if you feel uncomfortable, that's totally okay. We should remain uncomfortable. And this is my dog. Thank you very much.
Thank you so much, Dr. Nakagawa, for a wonderful presentation and some very interesting videos for discussion. If anybody has questions, could you please type them into the chat box? I think there were some that came along with the videos. Let me just see. I think for the one that where the physician just came out and told the person about his cancer, I think the comment was, I want to hear what follows after this exchange. The doctor's communication depends on how he'd show empathy with willingness to work with the patient to explore palliative options. Any comment on that, Dr. Nakagawa?
Is that what the second video?
I think so, yes.
So the question is how to follow up the conversation.
Right.
I see. It depends on, patient looks sad, so you have to follow up with addressing emotions. I'd say that it must be so difficult for you. I can only imagine how bad this is for you. And then I remain silent. That's how I would address emotions. And then he might say, then what's next? If he said what's next, that means that he's ready to move on to the, discussing next, the treatment options. So is it okay to, let's talk about the next step. Then I'm going to talk about, the treatment options. But before moving into that, you have a cancer, advanced, and he was sad. So you have to spend time to address emotions.
The next question is, can you give us tips on goals of care conversation, like giving bad news via telemedicine?
Oh, via telemedicine. Yes, telemedicine is really difficult because it's not live. You have to look at the screen. I think it's more difficult to catch the emotional cues through the computer screen. But I think the basic is the same. I use the same spikes and nurse and the wish statement. What the tips I would give you is, let's say, make sure patients is hearing what I say, speak slowly, and I'll talk about the, I'm going to come back, I think in February, how to, lead the family meeting. I'd say that at the time, but usually when you say the prognosis, some prognostic statement, that is the most emotional moment for the patient. So even without looking at the patient, patient's reaction, I follow up with when I say the prognostic statement that time is getting shorter. I follow up with, it is surprising to you. I follow up with the naming statement. That is one of the tips I use.
How would you handle denial in which the patient refuses to accept the prognosis?
That's a very good question. This is my opinion. When you hear that I'm a palliative care physician, I think you think of me as like I'm trying to make everybody DNR. I try to discourage all the aggressive chemotherapy. That's not true. That's not my job. My job, as well as your job as a medical professional, is to explain the medical condition as simple as possible, and then try to explain the all the available options. So, I used to gauge my performance of communication by the decisions they make. For example, when I was a fellow and I made somebody like DNR, DNI, I was like, yes, I did a good job. But that is wrong. I realized that that is a wrong approach. Because if you gauge the performance that way, you are going to lose with a certain percentage. Because you cannot change the people's opinions, all the people's opinions. So now how I look at that is, I'm going to, I'm okay for them to choose the full court press until the very end. I'm okay with that. But I'm not okay if they choose that option because of the lack of the conversation. Because I didn't do a good job explaining all the available options. I'm not okay with that. At the end of the day, they make the decisions. So as long as I do a good job explaining what I can control, then we should feel good. We should not feel frustrated by patient or family don't get it after you did your best job. That's how I see that.
How do you handle spouses or families who do not want their loved ones, the patient, to know the bad news? The patient wants to know it, but the loved one says no. Any practical advice or tips?
I think it depends on where you live, what the culture. I mean, did you guys watch the movie The Farewell? I think that's a very good movie. I think you should watch that. I think the approach is going to change where patient lives. When I face that situation, I mean, like all the textbook response is, I think we have to explore the family. So what are you concerned about? Most of the time you are going to hear, my dad is going to lose hope. I try to explain, I hear you, but you know what? Actually, our experience, a lot of studies have shown that it is not going to depress or crush the hope. They want to know. So I say that, based on my experience, we know that many people want to know. Not knowing the bad things is, not knowing things was much worse than not, hold on, I get confused. Knowing bad things is much better than not knowing. So I say this. And then I try to bring so I try to tell the family, so why don't they ask him? What would he say? He might want to know. And then try to bring the family at the bedside and ask the patient in front of the family. And then ask, what do you feel, Mr. Smith? And then if patient says, I want to know, then we cannot withhold the information. This is how I usually do. Having said that, it's not that black and white all the time. Sometimes family or the family member don't want to give the news to the patient. So in that case, I'm going to gauge that what is the consequence of telling the patient. By telling the patient, is it going to have a lot of difference, the practical difference in terms of treatment? Let's say patient is going to choose the CPR and the full court, but if 10 family members are going to be at the peace for the rest of their life, maybe the patient is okay to suffer for half an hour of the CPR. So I am going to gauge it might be not totally correct in an ethical way, but I think depending on the situation, I'm trying to be practical.
The next question is, do you explain palliative options, medical plans which follow, instead of giving the patient an impression that there's no plan, no option, that gives the patient a sense of abandonment? Of
course, you have to do that. I mean, I think the problem is that I think all the doctors, many doctors don't know how to explain the non-therapeutic options. Like if we stop the chemotherapy, how we treat the patient or family. When we don't do the curative surgery, how we treat the patient or family. We don't know how to talk about. So we have to emphasize, even if we don't do the chemotherapy, we can make sure, patient is, pain is well controlled and patient can go home. We have to emphasize a lot about the positives of not doing a certain treatment.
The next question is, do you have comments about what to do if the family is overwhelmed but time is limited, like in giving bad news in the emergency room?
I see. I think if family is overwhelmed and cannot make a decision, unfortunately in the US, I think we have to do the full court press. I mean, they, not being able to making a decision, I think is kind of making a certain decision. So if they are overwhelmed and they cannot absorb and they cannot make a decision not to do something, I think we have to do in the United States. It sucks, but I think it is a reality.
Right. Okay, this next question is, how might the following conversation be handled? The patient asked to know his condition. The son and daughter know the diagnosis, but don't want their father to know. As the physician was about to explain and discuss with the patient, the daughter stood up, said, "Thank you for coming. You can go now," and physically pushed the physician out of the house. Wow. That's
I think you have to gauge the consequence of saying that. Probably it's better to not to pick up the fight. If family is against about giving the news such a strong way, even if you give the news and then patient understands that, and then let's say patient choose hospice or die with DNR DNI, I think the family is going to be distressed probably for the rest of their life. So you might feel the some ethical dilemma, but we cannot change everybody's mind like we want. So in that kind of strong adversarial situation, I think it's okay to back off. That's in my opinion.
okay. Thank you so much, Dr. Nakagawa. We are out of time now, so unfortunately, there's still a couple of questions in the chat box, Dr. Nakagawa, but I don't think we'll be able to get to them. If you do have a moment, if you could look at the very last person's question and answer that, that would be wonderful. Several of our audience have been putting in comments about what a wonderful presentation this was with many practical tips. Right. So I thank you again and remind our audience that Dr. Nakagawa will be back in February for our grand rounds to talk about how to conduct a family meeting. So please join me in thanking Dr. Nakagawa for a wonderful presentation.
Thank you, everybody. I'm doing Twitter, so please follow me.
Thank you. Okay, bye-bye.